Thanks to everyone who's joining us for our latest podcast. We're really pleased that this is going to focus again on health and housing. It's a big programme of work for CIH and really important. And we're going to be looking at what research tells us and what that means for practice. And we are really pleased today to welcome Faye Sanders, who is a doctoral researcher in housing and health at the University of Bath, and has done some really excellent work, including a video, if you haven't spotted it, around the connections around housing and health. And also very pleased to welcome our own Dr. Eve Blezard, who's policy lead on assets, safety and culture. And as that sort of title tells you, we're going to be exploring the many varied ways that housing impacts on our health and well-being. It is as simple in one way as having a decent home, but it's not as simple as that. So we're really pleased to just crack on with this, and given that we have these two experts, I'm just going to launch into it. So Faye, I'd like to start with you if I can, and I'd just like to talk about why housing is health, why it's so important. You know, often we think about and take for granted the kind of physical health and safety issues, but you explore this and the other ways, the more kind of perhaps the less tangible ways that housing can affect health. So I just wonder if you could kick us off by talking a bit more about the research and why these less tangible factors can be as important.
Yeah, definitely. So I think historically, we've associated poor housing quality with lots of physical health conditions, so particularly respiratory health, and we're quite familiar with kind of the relationship between, for example, kind of mold in people's homes and respiratory health. However, kind of recently, and sort of, to be honest, over the last few years, we're definitely starting to understand more the relationship between poor housing quality and mental health as well. So the home is a really important sort of construct, and it relates to a lot of kind of components of our mental health. So it's meant to be an area of safety and security for us, but for many people, this is kind of far from true. And things that we previously associated with physical health, so damp and mold in the home, our research shows that these factors are also really important for mental health, particularly when we look at things like depression and anxiety. So when we kind of look at relationships between housing and health, it's not just physical health that housing quality relates to, it is also mental health. And some of our kind of latest research also tries to look at how, when we look at housing and health, mental health and physical health are not two isolated constructs. In fact, they relate to each other a lot, and there's loads of research looking at how mental health and physical health relate to each other. In the context of housing, we've found that people who experience poor quality housing, so things like mold and damp in the home, and low satisfaction with their home, they're more likely to experience more symptoms of depression, and that this is partly explained by kind of changes in DNA methylation, so a sort of biological component of our health. So yes, housing has a relationship with both physical and mental health, but also they're very sort of intertwined in how they work.
Yeah. Absolutely. Well-being. We're whole people, aren't we? And well-being is actually that physical and mental and emotional sort of sense of being safe and being well and being in control of things. So yeah, we can see how that knocks on. And it is stark when you actually look at how much of the impact on biological aging, for example, that poor housing can have, and even tenure base as well. It can be stark. I just like to turn to you, Eve, and just obviously your title is that you lead on assets, safety, and culture. So you also pick up on this in terms of it's beyond the physical aspects of home and the physical aspects of house. So I just wondered if you wanted to reflect on Faye's comments and on that question.
Yeah, and I think there's a lot in, although Faye and I have taken different research paths, it's really interesting how we've come to such similar sort of findings, if you will. And I think when we do think about health and safety and risk, we do automatically jump sort of straight to that very tangible, very physical. So whether that be maybe very physical responses to damp or cold or safety, and I just want to be clear that of course that's very important and very difficult to live with. But some of my research, similar to Faye's, will pull me back to maybe that less visible stuff. So my original doctoral research wasn't necessarily in housing sort of condition or hazards. It was just about life on an estate and how that was experienced. And what was really important was some of those less visible ways in how housing affects health. So whether residents felt that they were safe, whether they felt that they were in control, and I'm just picking back up on what Faye said about home, and it was very much that, whether they felt like they belonged. And interestingly, there were actually some residents in brand new properties that were very warm and very safe, but because of the way they were experiencing sort of safety and community in their area, they were really struggling to make that a home. And then this sort of then led into a lot of stress and anxiety. So residents would talk about not being able to sleep properly. They talk about just coming home and shutting the door because they didn't feel sort of safe. But there was also a lot of how residents had been, in my research, very clear about the importance of community space and green space, very clear about how they had always had quite a lot of autonomy over that space and involvement in that space, and that autonomy was really important. And that was kind of dismissed in the regeneration of that particular estate, which led to those health and well-being. And that's something I've really picked up in my policy role, is that when we look at things like quality and decency, it can't just be technical. It's got to be about understanding the culture and understanding how we listen to residents and really understand what it's like to live in that home. And I think that's where Awab's law plays sort of a really important part. So maybe previously a home could be technically legally compliant, but is still causing quite chronic stress, or it might be that it's not legally compliant, but we've not really got the right channels to listen to those residents, and those early warning signs maybe have been dismissed because of how residents have been perceived. So I think it's about understanding how we listen to and recognise what residents feel and describe as harmful, maybe and treating that as data and performance rather than waiting to see that in some sort of quantifiable way. So if we listen early, maybe we can prevent some of those problems. So yeah, it was just about how it's a really complex relationship between housing and health and well-being, and we've got to be prepared to research, but also put into practice how we understand some of that less visible stuff, and what does that mean for residents.
I think that's a really interesting perspective, and obviously we look very much at what it means within social housing and how landlords can support that. But Faye, I know that I just wonder whether you've got any reflections sort of in terms of wider tenure, or what support you see is missing to try and help people make home for them and address some of these less tangible aspects? I mean, from your, as Eve said, your research has come from different angles, but you're both coming down to actually there's something about home which is really intrinsic to health and well-being. And I just wondered if there were further reflections that you had, perhaps from the context of other tenures, or maybe even at some point you could talk about how health understands it and how they're starting to understand it, because I know a lot of your work has been quite health facing around the home, the importance of home.
Definitely. So in terms of when we look at sort of the general population, so I suppose when we look at people regardless of tenure, we see strong relationships between housing and both mental and physical health outcomes across different tenure types. So I think sometimes there's a bit of an assumption that poor quality housing is restricted to particular tenure types, but actually we see it across a very wide range of tenures. And that's important to understand, because if we want to use housing to kind of protect population health, then we need to understand and kind of work on the fact that poor quality housing exists in a very wide range of contexts, and a lot of our research has found that even in contexts of slightly higher socioeconomic status, for example, you still see those relationships between poor housing quality and health. So, I think there's a lot of sort of maybe myths around kind of housing quality and health, and some kind of stereotypes around what that might look like, but actually we see it in a super broad portion of the population. And I think that kind of supports application of, for example, the decent home standard to a wider portion of our housing stock, basically, and a general move towards a culture shift towards acknowledging housing quality as an important risk factor for both mental and physical health. I think in terms of sort of the health community, and when we talk about housing and health to the health community, I think in the past there definitely has been a bit of it felt like there was a lot of convincing to do on the fact that housing is an important factor in our wider, as a wider determinant of health, if you like. More recently, that does seem to be changing. There are many sort of NHS programs going on, which we actually talk about and refer to in the film quite a lot, which include housing as part of those pathways. So actually looking at the community, understanding some of those pre-admission stresses. So what are the things that are actually bringing people into NHS trusts? And the data shows that a lot of that is housing. And I think that data has been sort of invaluable in having those conversations around the importance of sort of investing in housing and joining up housing and health services together. There's been some excellent work done by sort of the NHS Sussex and NHS Hampshire and the Isle of Wight in those particular areas. So I think there's still quite a long way to go in terms of maybe more sort of senior NHS leadership and really leading on the housing front. But there's definitely excellent kind of examples of work that are being done that I think are really inspiring.
Yeah, that's for sure. And certainly in CIH, we're following some partnerships where they're looking at trying to build that as a natural strategic partnership, which means it becomes embedded in the different partners' corporate approaches and strategies and plans. And I think it's understanding some of how you use your data and your metrics, which obviously Eve raised, about how you can actually use that and gain understanding from it for all the partners involved, not just one or the other. It also raises some interesting questions about policy, doesn't it? And how our housing policy maybe needs to reflect that housing as a public good, not just a private benefit, but a public good in terms of our health and well-being for a nation. So that would bring some interesting challenges if we could think about policies for that. But I wanted to take us back to actually, well, what does this mean for us in practice? So, in terms of how integral and how in how many different ways home and housing is important for our well-being. What does that mean for some of CIH's members that are actually going into people's houses and seeing some of the issues raised? How do we relate this to practice, and how can we use your research to understand what we should be equipping our staff to do and what we could be expecting them to do in practice? Faye, shall I start with you and come to Eve then, if that's okay?
Yeah, so I think, first and foremost, I think the work that people do in housing is absolutely incredible. And I think there are so many sort of unsung heroes within the housing space. And I think that's sort of a real shame. But I think the work that sort of people are doing in the housing space is absolutely critical for population health, as the evidence is showing. So I think just first and foremost, definitely sort of acknowledge that. Secondly, I think something which, I would say is that so much of our evidence indicates that satisfaction with the home is a really important predictor of health outcomes. So we can, measure housing quality through, I suppose you would say, more objective methods, if you would want to call it that. But actually, what's the purpose of measuring housing quality? If the purpose is to protect people's health, then measures like people's satisfaction with their home is a really, really key indicator. And that relates to kind of what Eve was saying previously around understanding people's needs and kind of community needs and how they might change over time, how they might differ between different areas. And so the main thing to say is that satisfaction is an incredibly important thing to capture and to try and improve. And the way to do that is to understand what kind of your kind of community needs are.
That is really interesting. And so obviously we are in the social housing sector, we've got that back embedded with consumer standards and tenant satisfaction measures. But that's obviously on a kind of like organizational or, national scale. So there's still, I think, work to do in how we embed that in terms of local communities requirements and priorities. And that, I think, whereas, maybe some of our opportunities with integrated care boards, with the neighbourhood health centres being announced, actually going back to that neighbourhood level and understanding community needs would be brilliant. Eve, I just want to bring you in, obviously, because with being there at the interface of, translating policy into practice for our members and supporting them, what are your reflections on what it means for, our members, particularly those who are, really at that front of seeing the integration of housing and health?
Yeah, and I think at the moment it's quite a challenging time with policy such as Awaab's law and sort of residential peeps about, are we asking housing professionals to be medical, to be clinical, and really start to have a look at health impacts? And I think that's a legitimate concern for a lot of people. Is, wow, how do I have these really personal conversations about people's health, and how am I equipped to make judgments about that? And I think it's really key to sort of say that it isn't for housing staff to become health professionals. It's maybe about equipping them to do what they already do, but maybe with a different sort of lens on, and as sort of like Faye said, that Faye's research and well, my research and lots of other research, when you do that visit, you're often walking into the middle of a very long story, or the end of a very long story. People might be really frustrated, they might be disengaged, not because they're trying to be difficult, but maybe because they've been living with quite difficult conditions, or they've not been heard, or that trust has broken down. So I think that maybe some of it is a little bit around how do staff interpret what they're seeing. How can it spot some of those early warning signs? So maybe like that withdrawal, that sort of fear, and maybe is that data in itself rather than a barrier or background noise. And I think some of it is around legitimizing and valuing what we've always called, and I do hate the word, we've always called it like soft skills. So we tend to use home as this like sort of like emotional, sort of sentimental concept, which obviously it is, but it is a health and well-being concept as well. And in my research, residents were really clear that there was a difference between the house or the property you lived in and home, and making that home. And then everything that goes around that, I think, in housing, and where a lot of housing staff have real strength that maybe we don't always value and recognize, especially because day-to-day housing management is so busy, is that sort of early intervention, that communication, those relationships is what we determine as a soft skill, but is vital. It's vital to residents. It's vital to build those relationships, to make residents feel comfortable to share that kind of information. And I think also possibly makes visits safer for both resident and staff, and then maybe more constructive. And I think some of it goes back to what you were saying, Sarah, is that we've got to be clear that, and like Faye was saying, maybe not have to fight so hard, that housing is really important and it is a health issue, and that those joint partnerships really matter. So I was asked to write a chapter for a social work sort of like student, social work book, which kind of threw me initially. But part of that was because they were really trying to support social workers to understand, like you were saying, not really just that like housing as such and social housing, but that whole like neighbourhood perspective. Who else is working in this neighbourhood? What's missing in this neighbourhood? What works for residents in this neighbourhood? So I think where we've seen that sort of healthy housing partnerships, where not necessarily just sort of housing and clinical, but the community and the third sector come in, I think that's going to be really important. So maybe that message is, when it feels quite overwhelming for housing staff, that it isn't all for you to do. We need to work better at bringing loads of different people in, and it's very difficult. It's a very fine balance, because a lot of the legislation talks about health and well-being, but then says, oh, but you don't need medical evidence and you don't need to be trained to review medical evidence. But that's a real grey area. So I think that's something for CIH as well, and something for research findings to support organisations with that soft grey area. Let's value that, let's recognise that, and let's look at good practice in that, so we can make sure that staff have that sort of confidence to feel a little bit more comfortable in that area.
And that's actually really interesting, Eve, because part of some of CIH's work around health and housing is following some of those partnerships where they are working. And one of the things that is working in the example we've got in the east of England, across Bedford, central Bedfordshire and Milton Keynes, is exactly that. Public health have lots of resources around free training that actually can equip housing officers. And so around smoking cessation, conversations about exercise and obesity, and actually in some places they've looked at what their community's priorities are, and it is exactly things like that. I'd like to stop smoking, but I can't get into the referrals. I don't quite know how to manage it. I'd like to get healthier. I'd like to eat healthy food and stuff. And so they've actually got partnerships around some really practical priorities like that. But the issue is that public health understand what housing can do and the reach that housing can have, and but they've also got some resources that can make it easier for housing professionals, because it can be a sensitive thing going into a home and saying to people, do you want to stop smoking? Do you know it'll help with you paying your rent? You'll get more money back and have more disposable income, etc. It can be sensitive, but actually there are ways to do it, and the training's there. So it's really interesting. That's a very good point. It's very practical, but that's the partnership that's also trying to embed it at a strategic and operational level as well.
Yeah,
I'd like to. Sorry, go on, Eve.
Yeah, I think that has to happen, because I think if you're a housing officer and you're listening to this, you'd be thinking, I've got to help people stop smoking.
Yeah, exactly.
I've got a huge estate. I've got issues with antisocial behaviour. I've got to get rent in. I've got all these different, now our laws coming in, all these different things. So that has to come a little bit higher up, so that housing officer sits within that team and feels very comfortable. And the ones that I've seen work very well is where you're literally in the same building or the same office. So that the health improvement team might be right next to you, and so somebody from social services, and that works really well. So yeah, it helps support so that one person doesn't feel overloaded. Sorry, Sarah, I interrupted you then.
Absolutely, completely agree. And it is about how you make people understand that you're not doing this solo. I think that health and well-being, I don't know your reflection on this, is so complex that actually no one organisation, not the NHS, not public health, not housing, can actually achieve working directly with residents, patients, clients, can't actually achieve it. We need these partnerships at that place space. So Faye, I just wondered if you've got reflections from your examples on that, that actually each of us can bring a skill, and it's not about doing it alone.
Exactly. I think that's one of the things that over the last few years has really been highlighted, is sort of the power of collaboration. And I think at the moment we're probably still quite early stages in terms of the size of those collaborations that we're actually seeing, and that's quite an exciting area, I think. So even if it's between, for example, NHS trusts and housing associations, or housing associations and sort of universities and sort of the research side of things, I think there is so much to be done in terms of sort of using people's skills to the best that we can, and actually coming together and sort of whether that's, for example, using kind of the research skills, and then often in research we're always complaining about the fact that we have no data. Well, there is that data out there, but maybe it's kind of maybe a bit hidden away, or people aren't aware that how useful that sort of data could be. So I think absolutely collaboration is the way forward, and I think there's already evidence to show particularly with those NHS partnerships, how successful they can be and how effective they can be in improving kind of population health and how communities are actually feeling.
Yeah, no, thank you. So we could talk about this for ages. You could tell that we're very passionate about it, and we could talk about it for a long time. But in terms of coming towards the end of this podcast, I suppose the obvious question is, well, what needs to happen next? If you in terms of achieving more of embedding housing within a health and well-being approach, perhaps seeing it again as it used to when it started as a public function, seeing it as a public health function, what do we need to do? What do you think are the next steps to try and make this become embedded as an approach, and seeing the best of the examples you two have highlighted coming through. Faye, shall we start with you? What do you think needs to happen next?
I think so. On the topic of collaboration, I think that should be sort of a number one priority, is actually starting those collaborations. And I think sort of related to that, but slightly different, is actually systematically capturing community needs, and understanding the conditions of housing stock kind of across the UK. I think we can do a better job of understanding those, particularly in terms of satisfaction with housing and how that differs. That would be kind of a number one priority, I think, is the collaboration side, setting up those collaborations, building those relationships, because it does take time to kind of build that trust, start kind of speaking in a similar language, and understanding what the different priorities are for the different stakeholders. That takes time, and it isn't something which is just done instantly. So I think, the sooner those relationships, start to grow, the better. And also, understanding kind of community and population needs, and capturing that to the best of our ability where we can.
Thank you. Eve, come to you for your thoughts. What do we need to do next? What's the next step?
Yeah, I think we've spoken about how we sort of bring the sometimes separate worlds of policy research and practice closer together, and Sarah's heard me talk about that many times before. I think as a sector, a little bit as a housing sector, we need to be a little bit more better equipped at how some of that lived experience data is recognised as data and valued as data. So how is that resident experience and evidence sort of taken sort of seriously, and how maybe we use that to shift a little bit from being kind of reactive sometimes and into maybe more preventative. And a lot of the regulation that and policy shifts that we've seen, particularly with things that have come out sort of post Grenfell, talk about how we need to shift culture change, because we have dismissed residents, we're not listening to them, but we haven't really got any sort of metrics or measures to identify and sort of measure both how we are improving in terms of our culture, but how we incorporate some of that lived experience. So I've seen some providers use more value-based metrics, like a scorecard or something like that, so that we can really be clear that we've got the TSMs, and you've got all these standard performance metrics that you would see. How do you raise that resident experience up so we're giving it the same value, and we're tracking it? And then I think some of that then helps us go back to residents and build that trust back up, because we can evidence we are sort of listening, and we are bringing that in and working with and for rather than to, and I think that will help. And I think we've got to acknowledge that that's actually probably quite a long road that we've got to go down, and that isn't going to be an overnight sort of fix, really. And some of that shift around our mindset around the way in which we measure and value some of that soft experience and soft work, whether that be skills from staff and the lived experience of residents, because I think when you look at impact and risk in terms of safety and decency, that's very personal and very individual to that resident, and some of the solutions that work for one resident then won't work for another. So we've got to be a lot more open in terms of how we listen to the way homes are lived in and experienced.
Yeah, no, that's true, and that's I think that's some of the aim of some of the tools that CIH has been working with, some partnerships like the Insights Bank, hopefully really gaining that kind of understanding of how people live in and interact with their home in a way that's also valuable evidence for health and social care partners as well. And obviously this can happen even within the environment of change, because we know that the NHS is probably the one area where it kind of there's reform every year, and ICBs was seen as a good forum, but there's changes happening there. So it's a bit like, give us an opportunity to take a breath and start forming those partnerships, isn't it? Really, it would be also one of mine. We do need the collaboration, as Faye said, and we do need to have those conversations. The collaboration needs to include our residents, our shared kind of like cohort community, but actually we could do with a bit of time and space to develop it as well. That would probably be my please give us that space to actually do some of that good work. I think we could probably go into far more questions, but what I just want to say thank you very much, and we'll probably carry on part 2 of this conversation further down the line as well. But I wanted to say thank you very much for your time and reflection on the health and housing partnerships and why we need to understand the research and share the research and make sure that it becomes something that happens in practice on the ground for us to make improvement around health and well-being, using the home as a hub for it. So and look forward to speaking to you again on this. But I just wanted to say thanks very much to everyone for listening. Thank you to Faye Sanders from the University of Bath and to Eve Blezard from CIH. Thank you for coming in and listening to this, and let us know what you think of this and how you feel we need to try and translate some of the research, some of the best practice into what you can do with your tenants and residents in your communities, because we're very keen to know how we can support and equip you and inspire you to do that very much in your local area, so that you see benefits for your tenants and residents. So just like to thank you very much again for joining on this podcast. Look out for the next podcast, and look out for the next health and housing input as well. So we just like to say thank you very much, and see you again soon.